I'm a medical oncologist from the Dalian Medical University. We just thanks so much. Solange Peters gave us the excellent speech, and we just got overview of strategies in treatment of EGFR mutant non-small cell lung cancer. And in my clinical practice in China, so many patients with EGFR mutant non-small cell lung cancer. In medical oncology department, we meet a very huge of a number of metastatic stage. We use the monotherapy or combined TKI together with chemo or angiogenesis according to subtype of EGFR mutant, or we consider the co-mutation or not. I think it is very important for doctor to balance the benefit and the risk, and we can balance the efficacy and the toxicity in my clinical practice. I have a question to ask Professor Peter. If there is a patient, EGFR mutant metastatic non-small cell lung cancer patients with the high expression of PD-L1 expression, more than 50%. What do you choose? Use EGFR TKI at first or PD-1 antibody at first? I just heard some American doctors use PD-1 at first, PD-1 antibody at first. In China, we use the TKI at first. I would like to know the role of expression of PD-L1 expression in mutant non-small cell lung cancer. Can it influence efficacy of EGFR TKI in clinical practice, or it can be predict efficacy of PD-1 antibody after progression of TKI failure? How about your opinion?
Thanks so much. This is always a field of debate. So we have data, and to be very honest, we always speak about AGA, actionable genomic alterations, as the group. It's probably slightly wrong because the data we have is about EGFR and ALK only. But let's imagine it's for all of these never smokers kind of oncogene addiction. What we know is not only the EGFR mutation expression pattern, but also the whole environment of EGFR mutated tumors create an environment genetically where PD-L1 is usually overexpressed. So what I mean by that is the EGFR mutation biology creates this interferon gamma signature, which basically makes the tumor to be very often PD-L1 expressed. But it does not mean T-cell exhaustion. It means just EGFR mutation and how this is perceived by the immune system. So what I mean by that is if you have PD-L1 of 90, 80, 70, this is wrongly predictable of PD-1, PD-L1 efficacy because it doesn't mean T-cell exhaustion. It doesn't mean you can reactivate T-cells. It just means they biologically express PD-1 and the tumor biologically express PD-L1 because of the mutation. So you cannot use PD-L1 as a predictive biomarker. We call it is the expression of PD-L1 is oncogenically driven and not immunologically driven. Okay, but I would put a but on that. This is true if you have 100, 90, 70, 50, you cannot use it. And usually immunotherapy has a weak efficacy, so it's never a frontline treatment. It can be a late line treatment like in the Orion 31, for example. But what do we see from this trial combining chemo and checkpoint? We see that in all of this trial, there is a little benefit of IO, and the benefit becomes strong if you remove one subgroup, is a negative PD-L1. Because, I explain myself, if you cannot measure the positivity because it's oncogenically driven, so it's betraying you, negative is negative. Negative means that you don't have any T-cell exhaustion, right? So it means that whatever you do, PD-L1 with not PD-1, PD-L1 inhibitors will not work because the phenomenon of immunogenicity does not give rise to T-cell exhaustion. So while you cannot use by 50, 80, 90 as a biomarker, negative is negative. If you have a negative PD-L1, if you give a checkpoint, it doesn't work. So what I mean by that is, no, you cannot use PD-L1, but in late lines, if I hesitate for an ADC versus Harmony A or versus Orion 31, I would probably just exclude from the immunotherapies the PD-L1 negative patients. In this patient, the response rate is 0%, right? But that's the only the discussion. But otherwise, immunotherapy is a late line. It has to be combined with chemo. It has to be combined with anti-angiogenic and probably only in positive PD-L1. But it's late line treatment. TKI first.
Thank you.